Welcome to LEMP Pharmacy Tutorial. Today, we will be looking at the pharmacology of oncology.
Drugs.
All right, so here's what we've got on the cards for today. We're going to start with the absolute fundamentals, the cancer cell's life cycle, which is really the battlefield itself. Then we'll move on to the heavy artillery, the DNA-damaging agents, before looking at the saboteurs, the metabolic and mitotic inhibitors. After that, we'll dive into the really modern stuff, the smart weapons like targeted and hormonal therapies, and of course, immunotherapy. And we'll wrap it all up with what is arguably the most important bit, the clinical reality of managing side effects.
Right then, let's dive in. Because before we can even begin to talk about the weapons, we first have to understand the battlefield.
You see, at its very core, cancer is a disease of uncontrolled cell division. It's essentially a cell that's forgotten the off switch and just keeps copying itself over and over. So it makes perfect sense that for many of our traditional chemotherapy drugs, the main point of attack is this very process, the cell cycle.
Now, every single cell, whether it's healthy or cancerous, has to go through these steps to replicate. Think of it like a production line. In the G1 phase, it grows and gets all its resources together. Then comes the S phase. This is the big one, where it meticulously copies its entire library of DNA. After that, in G2, it does a final quality check. And then, finally, in the M, or mitotic phase, it splits into two identical daughter cells. Each of these steps is a potential vulnerability, a place where we can intervene.
And this leads to a really crucial distinction in how these drugs work. Some are what we call cell cycle specific, meaning they only work their magic during a specific window of opportunity, like when the DNA is actively being copied. Others are nonspecific. They can damage the cell at pretty much any point, even if it's just sitting there in a resting state. And that difference completely dictates how and when we use these drugs clinically.
Okay, so with that distinction locked in our minds, let's move on to our first class of drugs, the real heavy artillery, the ones that launch a direct assault on the cancer cell's DNA.
First on the scene are the alkylating agents. These are some of the oldest and most powerful chemotherapy drugs around. Their mechanism is, well, it's brutally effective. They permanently attach to the DNA, creating chemical crosslinks. You can imagine it like a spot weld, physically gluing the DNA strands together. And once that happens, there's just no way the DNA can unwind to copy itself, which, for a dividing cell, is a fatal blow. So yeah, it's like chucking a massive wrench right into the cell's core machinery. But because it's such a non-specific attack, it causes a fair bit of collateral damage. Bone marrow suppression, myelosuppression, is common to almost all of them. But many agents also have their own unique, shall we say, signature toxicities. Cyclophosphamide can cause severe bladder damage, while the platinum agents like cisplatin are notorious for being toxic to the kidneys and nerve.
Let's just zoom in on that bladder toxicity for a moment, because it's a fantastic example of clinical problem solving. It's caused by this really nasty metabolite called acrolein. As this chemical builds up in the bladder, it causes severe irritation and bleeding. But, and this is the clever part, we have an antidote. A drug called Mesna is given at the same time, and it acts like a molecular sponge, specifically soaking up and neutralizing the acrolein in the bladder before it can do any harm. Brilliant, isn't it? And that idea of using one drug to manage the side effects of another is a core theme you'll see again and again in oncology. Now, while alkylating agents smash the machinery, our next class of drugs is a bit more subtle. They sabotage the assembly line itself. These are the antimetabolites. If alkylating agents are a wrench in the machine, these are counterfeit parts on the assembly line. They are exquisitely designed molecular mimics, made to look exactly like the building blocks cells use to construct new DNA. They are, in essence, cellular imposters.
So the cell is tricked. It tries to incorporate these faulty parts into its growing DNA chains, or the drugs simply jam up the enzymes needed for synthesis. Either way, the whole S phase grinds to a halt. And of course, they come with their own unique toxicities, like the painful hand-foot syndrome that we often see with capecitabine.
Now for another group of saboteurs. These ones don't target the building blocks. Oh no, they go after the cell's internal skeleton, the microtubules. These protein filaments form a critical structure called the mitotic spindle, and its job is to physically pull the chromosomes apart during that M phase of division.
And here's the fascinating part. We have two classes of drugs that achieve the same goal through completely opposite means. The taxanes, like paclitaxel, overstabilize the microtubules, freezing them in place so they can't come apart. And then you have the vinca alkaloids, like vincristine, which prevent them from forming in the first place. One freezes the skeleton, the other dissolves it. The end result is the same. The cell gets stuck in mitosis and dies. And speaking of vincristine, I have to stop and stress this point. It is one of the most important safety warnings in all of oncology. It must never be given to the spinal fluid. Accidental intrathecal injection is uniformly and tragically fatal. So the drugs we've discussed so far are a bit like carpet bombs. They hit all rapidly dividing cells, cancerous or not, and that's why they have such extensive side effects. But the modern era of oncology is all about precision. So let's talk about the smart weapons.
Instead of those broad, cytotoxic attacks, targeted therapies act much more like guided missiles. They're engineered to interfere with specific molecules, often a mutated protein or an overactive signaling pathway that a particular tumor relies on for its growth and survival.
One of the largest classes of these drugs are the tyrosine kinase inhibitors. And here's a fantastic clinical shortcut for you. A huge number of them end in the suffix -nib. So when you see a drug name like imatinib or erlotinib, your mind should immediately jump to, okay, small molecule targeted therapy, kinase inhibitor. It's a great little trick.
But perhaps even more revolutionary is immunotherapy. This approach doesn't target the cancer cell at all. Instead, it targets our own immune system. You see, cancer cells are clever. They can display proteins on their surface that essentially act as an off switch to an approaching immune T cell. They basically say, nothing to see here, move along. Checkpoint inhibitors block that off switch, effectively releasing the brakes on the immune system and allowing our own T cells to finally recognize and destroy the cancer.
Now, not all cancers rely on internal mutations to thrive. Some of them rely on an external fuel source, our own hormones. And that gives us another very clever therapeutic strategy. We just cut off the fuel supply.
In hormone-sensitive breast cancer, estrogen is the fuel. But how we cut it off depends critically on where the body is making that estrogen. In premenopausal women, the ovaries are the main factory. So we use a drug like tamoxifen to block the estrogen receptors directly at the tumor site. But in postmenopausal women, estrogen is mostly made in other tissues by an enzyme called aromatase. So there, we use an aromatase inhibitor, like anastrozole, to shut down the factory itself.
And with tamoxifen, there's a vital piece of pharmacology to remember. It's a prodrug, meaning it's inactive when you take it. It must be converted into its active form by a liver enzyme called CYP2D6. Now, if a patient is taking another drug that strongly inhibits this enzyme, and certain antidepressants are common culprits, that conversion is blocked. The tamoxifen simply won't work effectively. It's a massive deal.
All of these powerful drugs, from the oldest to the newest, come with a cost. And no discussion of oncology pharmacology is complete without turning to the clinical reality of managing their side effects. The single most common reason a dose of chemotherapy has to be delayed or reduced is myelosuppression. Because the bone marrow is a veritable factory of rapidly dividing cells, it's highly susceptible to cytotoxic drugs. The result is that the production of all our key blood cells just plummets.
And that drop leads to three main clinical problems: low neutrophils, or neutropenia, which dramatically increases the risk of life-threatening infection; low platelets, or thrombocytopenia, increasing the risk of bleeding; and low red blood cells, causing anemia and fatigue. Thankfully, we can intervene. We use biologic agents called colony-stimulating factors, like filgrastim, to specifically boost the bone marrow's production of neutrophils and get patients safely to their next cycle of treatment.
Beyond myelosuppression, many drugs carry a unique toxic fingerprint. Honestly, if you remember nothing else, memorize this list: cisplatin, kidneys and ears; vincristine, peripheral nerves; bleomycin, lungs; cyclophosphamide, bladder; and doxorubicin is famous for its potential to cause long-term damage to the heart. Knowing these pairings is an absolute cornerstone of safe practice.
So there you have it. We've really journeyed from those blunt instruments that attack any rapidly dividing cell to the precision of therapies that target a single mutated protein, and even further to therapies that unleash the patient's own immune system.
And this constant evolution, this move from sledgehammers to scalpels, it raises a crucial question for the future. As our medicines become ever more precise, how will our role as pharmacists and clinicians need to evolve to manage their unique and complex toxicities? It's a question that will define the future of our profession. Next episode, we will be talking about anti-cancer drugs and chemotherapy. Be sure to join in.